Hi guys, we'll go ahead and get started now. Today, it's a very, very common problem. We see them all the time. Sometimes we're doing kind of 10 spinal surgeries a week. Between do at least 2 during the week. And so, and this is one of those conditions that if you do surgery and you get them early, the prognosis is generally really, really good. So I'm going to go ahead and switch to the lecture, and as always, we have the live chat going on the right-hand side of your screen, and if you have any questions as we're going, please don't hesitate to ask. I do have somebody monitoring the live chat, and we will answer those questions as they come up. So I've got a few different questions that I intend on answering during this discussion. The first is, why do discs rupture? What are indications for surgery? What's the prognosis with surgery versus conservative management? And what does the lack of deep pain mean? And I think these are the really important issues when you're considering disc disease in dogs. So I'm going to break from my presentation for a second, just so I can go in and show you a video. So this is a dachshund that unfortunately has lost deep pain sensation, is completely paralyzed, and this is kind of the typical appearance when they can't walk. And so this is what we're trying to avoid by going to surgery early and decompressing their spinal cord, so we don't run into this problem very frequently. So why do discs rupture? And I'm sorry, I'm going to go back here and try to get my pointer on here. So why do discs rupture? And so this picture here shows a really desiccated disc, and that's the main underlying reason why discs rupture, is that that the nice soft spongy nucleus pulposus loses the ability to retain water, and so it becomes brittle. The first thing when we're discussing disc disease is that there are 8 or 10 different terminologies that are kind of covering the same thing, and I think that the inconsistency in the terminology makes it kind of challenging to understand exactly what we're dealing with. Anywhere from disease to prolapse to rupture, herniation, protrusion, extrusion, bulge, displacement, etc. And so for consistency, we're going to use intervertebral disc displacement. And what that means is that we've got intervertebral disc that goes beyond the bounds of the intervertebral disc space, and it most often occurs after degeneration. We do have 2 different classes of disc ruptures. We have the Hansen type 1 and the Hansen type 2. Hansen type 1 is usually an acute disc rupture where the nucleus pulposus explodes through the annulus fibrosus, and then we have Hansen type 2, which is just a bulging of the annulus fibrosus, which causes more gradual clinical signs. So just a quick review of the anatomy. We have the spinal cord here that's lying within a bony canal made up by the vertebral bodies. And then separating the vertebral bodies, we have the intervertebral disc sitting right there. And so we have the vertebral bodies here and here, have the spinal cord lying in the middle, dorsal spinous process here and here. This is the articular facet here and here. And then the disc sits in the middle. And then this is a diagram of a human spinal canal and column, but this very clearly illustrates what we're talking about here. So we've got the spinal cord that's sitting here inside the arachnoid, and then you have the dura mater, which is a very hard structure that surrounds the spinal cord and the nerve roots. And then we have the intervertebral disc space sitting right here. You have the nerve roots coming out on either side. And then when we look more closely, we have the nucleus pulposus, which is sitting in the middle here, and we have the annulus fibrosus, which is an onion ring-like structure on the outside here. So the function of the nucleus is to restrict compressive forces. And so when the nucleus is compressed this way, it's supposed to expand out laterally like this. And then the annulus fibrosus is what restricts unlimited expansion of the nucleus pulposus. And so what happens with disc disease is that that the annulus fibrosis, which is supposed to be restricting the expansion of the nucleus under compression, loses the ability to restrain that nucleus pulposus, and ultimately it explodes out into the spinal canal and causes compression of the spinal cord. So the normal disc contains about 80% water. It's a very, very spongy structure, and the ability to maintain that water is normal function of glycosaminoglycans and those sorts of things. And just like in a situation where, like in a wheelchair, where you have a water pad, that water functions really nicely to absorb impact and to distribute the impact. So if you have weight bearing down right here, like this, the water is going to expand out to the outside and make for a very nice congruency between the patient's or the person's bottom and the wheelchair. So dachshunds are prone to disc degeneration, and what happens is that the nucleus pulposus, which is sitting here, loses the ability to absorb and maintain water for some reason, and this is a congenital problem in dachshunds and other chondrodystrophic dogs. And so the normally very liquid, spongy nucleus pulposus becomes very dry and brittle, and is no longer retaining water like it's supposed to. So this is a radiograph of a dog that has disc disease, and we can see here the calcified disc that's sitting in the intervertebral disc space. And so this is a sign, if you take radiographs of a dog that's not showing any clinical signs and it has multiple calcified discs, that's suggestive that it's going to develop disc disease in the future. So the nucleus loses the ability to hold water, and so it becomes very, very dry. The nucleus can no longer resist compressive load bearing. So when you have this very dry disc that's no longer spongy, it cannot resist compressive load bearing. And so the compressive load bearing is transmitted to the annulus fibrosis instead. And the annulus, being as that it's has linear bands radiating, or circling around the disc, they can withstand tensile forces very, very nicely. So when you have a disc that's trying to expand out in all directions, a normal annulus can withstand tensile forces very nicely, but it cannot withstand compressive forces. And that's what happens when the nucleus pulposus dries out. So the annulus cannot resist compressive forces well. And I use this picture tongue-in-cheek because we are talking about sausage dogs. And the annulus becomes stiffer and weaker, and it leads to structural failure. And so the disc material explodes out from within that disc space. And so then you have intervertebral disc displacement. So this is an MRI of a patient, and you can see sitting right here is a disc that's exploded out from the intervertebral disc space right here and is compressing the spinal cord. So the spinal cord is now compressed like this, and you can imagine that neurologic transmission is not going to get through that very well. And so that's the cause of the clinical signs that we see with disc disease. And so just like a tire that has been emptied of air, when you have that dry annulus fibrosis, all of the road irregularities down here get transmitted straight onto the axle of the tire, which then gets transmitted straight onto the chassis of the car. And so that's what happens when we lose the ability to withstand compressive forces. So interestingly, in dogs, the annulus fibrosis is thinnest right underneath the spinal cord. That's in contrast to humans, where it's thinnest out here. So a human disc, instead of looking like this, looks like this. And so it's thickest underneath the spinal cord and thinnest out to the side. So you know that when humans get disc ruptures, they get the disc ruptures out to the side like this, whereas dogs get disc ruptures straight up onto the spinal cord. So very poor design, if you ask me. And so that's why humans, when they get disc disease, often just get pain and rarely get primary spinal cord dysfunction, whereas dogs often get paralyzed. So This is a diagram showing, again, the intervertebral disc that's exploded out to the side right here and has impacted the spinal cord. And so then we're having irritation of the nerve root as it passes from the spinal cord, and that's what's causing the pain. And then you also have compression of the spinal cord, which is causing neurological dysfunction. So in chondrodystrophic dogs, which are dachshunds, basset hounds, Maltese, Shih Tzus, things like that, all intervertebral discs, every single one of them show signs of degeneration due to a fault in abnormal synthesis of the extracellular matrix. So if every site is affected, why are some sites more prone to rupture than others? So there are a couple of things anatomically that help restrict the disc from exploding out into the spinal cord. And I'm sorry, again, this is a human diagram, but we have the structure right here, which is the dorsal longitudinal ligament. And that extends all the way back to about kind of T11. And the dorsal longitudinal ligament restricts the explosion of nucleus pulposus onto the spinal cord. And so that's one of the reasons why we don't see disc disease occurring cranial to kind of the T11, T10 region. The first report of intervertebral disc disease was about 140 years ago, and it was a dachshund that had acute disc paralysis. So this condition has been around for a long time. There was a study done by Priester that showed that the incidence in all dogs, so this was all breeds of dogs, the incidence was about 23 cases per 1,000 dogs. He found that the Pekingese, Dachshund, Shih Tzus, Lhasa Apsos, and Beagles, all chondrodystrophic dogs, so remember the chondrodystrophic breeds of dogs, they're the ones that are more likely to get disc disease. And all at-risk breeds, the peak occurs at about 4 to 6 years of age, in contrast to other breeds which occur at a later time, 6 to 8 years of age. And so if I have a dachshund that's about 8 or 9 years old and it's never had evidence of disc disease, I won't say it's completely out of the woods, but I think that it's less likely that that dog's going to develop disc disease than one that's, say, 4 or 5 years of age. So there's another study of disc disease done by a surgeon or a neurologist named Dr. Horline, and he looked at about 2,400 cases, and 65% of these dogs were dachshunds. Okay, and so dachshunds represented 10 times the incidence of disc disease compared to any other breed. He found a peak at 5 years of age, and 75% were between 3 and 6 years of age. So again, if you have a dachshund that's not shown any clinical signs beyond about 6 years of age, you start thinking about maybe we might be out of the woods, or at least lower incidence or lower likelihood that they're going to rupture a disc than if they were younger. There's another study of 536 dachshunds done by Dr. Goggin, and he found that 19% of dachshunds develop disc disease at some point in their lives. And so if you see 5 dachshunds running through the park, one of them is going to have significant disc disease requiring treatment, including possibly surgery. And there's no obvious inheritance within this study. And the other thing that's really important to note is that in 25% of the affected dogs, the disease is fatal. So that means that basically 5% of dachshunds are going to die of their disc disease. And that number can be significantly decreased if you treat these quickly and decompress the spinal cord in a hurry. We've got a couple of questions there. Is there anything, Mariana, that... Nothing?
Saying hi.
Yeah.
Somebody needs to be back on the OR with you, learning from you.
That's great. Thank you. All right. So when we're looking at the history, if you are a veterinarian watching, these are the important questions that you're going to want to ask the client. And if you're a pet owner, these are the questions that you're going to want to know the answers to when you're coming into your consultation. Really important is, when do the clinical signs start? If they started today, or yesterday and the dog is already paralyzed, I'm going to be much more concerned about that than if it started 3 weeks ago and it's not paralyzed. So if the signs are kind of slow and chronic and insidious, that is much less of a surgical emergency than one that went down today. Really important is, when's the last time voluntary motor function was seen? And the reason why that's so important is because kind of the 24-hour mark, the 24-hour mark is kind of what we think of as far as prognosis is concerned with disc disease, greater and less than 24 hours. If they lose deep pain sensation, if it was present within the last 24 hours, that's a sign that we're going to have a better prognosis. And if it was absent for more than 24 hours, it's a sign that we're going to have a worse prognosis. And generally, you can't lose deep pain sensation as long as you have voluntary motor function. Is he or she posturing to urinate and able to urinate? That's important for two different reasons. Number one, urinary obstruction is a really, really significant clinical sign in these dogs, and you can actually rupture a bladder or do significant damage to the bladder. The other is that it's an important clinical sign because if they are unable to urinate and they have a flaccid bladder, that could be a sign of either a very low disc in the lower lumbar region, or it could be a sign of potentially ascending and descending myelomalacia. Have there been previous episodes of disc disease? Has there been a response to medication? So I'm really interested if there's been a significant response to nonsteroidal anti-inflammatory drugs. That suggests to me again that it's very likely to be an inflammatory process, unlikely to be something like a fibrocartilaginous embolism or something like that. And then if they've been on nonsteroidal anti-inflammatory drugs, has there been any vomiting? And the other thing that's really important is black tarry stools, vomiting blood, anything like that, because perforation of the gastrointestinal tract obviously is a really, really bad thing if that happens, and that's something that we're going to want to know before we start treating this patient. So on physical examination, things that we're looking for: abnormal nail wear. Sorry, this keeps dropping out on me. Abnormal nail wear is going to be a sign of chronicity. So if it's been going on for a long time, they'll have wearing of the nails. And if somebody comes in and tells me we've had an acute deterioration of clinical signs today, he was normal yesterday, but I look at the nails and they're worn down, I'll say, okay, this has probably been going on longer than what we might have not have realized. The other important thing is forelimb lameness. And the reason why I'm interested in forelimb lameness is that if you have a cervical disc rupture, so up in here, and we have impingement of the nerve roots that are coming out in the neck, that's going to be a sign of a root signature cervical disc rupture. Schiff-Sherrington posture is this posture where the legs are sticking out straight and often the back legs are flaccid, and that, while it isn't necessarily a grave prognostic indicator, it can be a sign that we've got pretty significant compression of the spinal cord in the thoracolumbar junction. And then the other really important one is the flaccid anus. If we have a flaccid anus, that could be a sign either of a very low lumbar lesion or ascending and descending myelomalacia associated with severe spinal cord injury. So when we do our neurological examination, what we're trying to do is, number one, try to determine if there is neurologic disease or if it's orthopedic disease. For example, dogs with bilateral cruciate ligament ruptures can look a lot like a disc rupture, and they can occur in similar breeds. And then the other thing that we're going to try to do is determine the level at which we have compression of the spinal cord. So what is the level of the lesion? And the way that I like to think about it is that we have the spinal cord going down the middle, and then we have different nerve roots that are coming out at different levels along the way. And depending on the combination of the long tract signs that we see with spinal cord injury and then the shorter tract signs that we might see with cranial nerves or forelimbs or hind limbs, are going to help us localize exactly where along the spinal cord we have a compression. The other thing that some people use, I don't use as much, is the panniculus reflex. And that, again, is using the panniculus reflex, which is characterized by pinching or poking the skin along the spine and then seeing where we lose motor function as we head from cranial to caudal. So During our neurologic examination, one thing that's really important is to try to find clinical signs or to rule out clinical signs of intracranial disease. And that would be more suggestive of a brain tumor or something like that. And often a brain tumor is hard to distinguish from a cervical disc or a cervical lesion. You can have the same clinical signs of ataxia, neck pain, those types of things. So you want to make sure that we're ruling out intracranial disease. So things that we're looking for would be a head turn, dullness or stupor, circling in the direction of the lesion, a head tilt in the direction of the lesion, and then any history of seizures would be important as well. Now, my videos are not working within the app, and so I'm going to come back out of the app and then show my video here. So this is a dog that presented to a neurologist in the US, and you can see that he's really dull mentally, and he's turning his head to the left, and he's totally unaware of his surroundings. So this is, he's got no postural reflexes, no motor function at all. And so this is classic for a cerebral lesion. Interestingly, he's blind on the contralateral side, so we're expecting a left-sided lesion, and so it makes sense that he'd be blind in the right eye. And he's got lack of sensation on the right side of his face, which is again contralateral to the location of the cerebral lesion. This was GME, or granulomatous meningoencephalitis, and he was treated with steroids, and 5 days later you can see that he's completely returned to normal. So it's a happy story there. So we'll move back to our video presentation. So the other thing that we're going to want to look at is the presence of pain. Where can we localize pain? So we're looking for pain in the cervical region, the thoracic region, the lumbar region, or in the sacrum, and that's really going to help us identify where we have compression of the spinal cord. If the forelimbs are not functioning normally, and it's a single lesion, solitary lesion, then the cervical spinal cord has to bear the problem. If the forelimbs are functioning completely normally, then we think more of the thoracic or lumbar region. Remember that you can have very low cervical lesions that can still be normal in the forelimbs. So just because it's normal in the forelimbs does not mean that it's not a cervical disc. It would just have to be a very low cervical disc. And then remember that we talked about limping on a forelimb, which would be, or could be, a sign of a root signature with nerve root compression as the nerve root is leaving the spinal cord. So the other thing, or the next thing that we're going to look at, is for wobbliness or ataxia in the back legs, and that's also known as conscious proprioception. So we are going to go back out and video. See if I can enlarge that a little bit. So this is a dog that is ataxic in the back legs, and as he ambulates, you'll see that he just kind of ambles along and kind of dragging his back legs, and you can see that his rear legs are really ataxic, and I think that in this video he knuckles over at one point like that. So that's a sign of spinal cord injury. Could possibly be a peripheral neuropathy. The way that we would distinguish that would be to check our reflexes in our back legs. So if we had spinal reflexes in the back legs, that would be a sign of an upper motor neuron lesion, whereas if we had no spinal reflexes in the back legs, that would be a sign of either lower motor neuron or peripheral neuropathy. All right, so back to our lecture. The other thing that we look at is a crossed extensor reflex, and a crossed extensor reflex is where when you pull on one foot, they push the other foot out, and this is an abnormal finding in dogs. So I'm going to come down here and I'm going to pinch one toe right here, and you'll see that the other foot pushes out, and that is a sign of a spinal cord lesion or an upper motor neuron lesion, as opposed to a lower motor neuron lesion or a peripheral nerve problem. Okay, now one of the most important diagnostic tests that we can do in determining the prognosis in dogs with disc disease is to see if they have deep pain sensation intact. So deep pain is, again, one of the most important prognostic signs that we can use when we're predicting outcome with these guys. And it's really important to differentiate a reflex withdrawal from actual sensation. So one thing that we like to do is to try to do it when they're asleep and see if they wake up. So that's the kind of conscious response and sensation of the pain stimulus that we're trying to see. And if it's absent, it's a poor prognosis, but recognize in one study that 76% of dachshunds specifically with loss of deep pain still recovered function after decompression. And when you do lose deep pain sensation, it's really important to decompress these early. And we kind of say that kind of 12 to 24 hours is the magic window, whereas if you do it before 12 to 24 hours, the prognosis is significantly better than if you do it after 12 to 24 hours. And so differentiating whether it's a reflex or a reflex withdrawal or actual sensation, when you pinch the toes, you really want to see a conscious response to that. So it's not just that they're pulling the foot back, you actually want to see them yelp or vocalize or turn their head to the side of the pinch. And so a lot of times I have owners come in and say, oh, we definitely have deep pain sensation because when I pinch the toes, they move the feet, but that is not deep pain sensation. That's actually just a reflex. And you could literally transect the spinal cord with a scalpel blade and you would still have a withdrawal reflex. So really, really important to make that distinction. The other thing that's really important is primary care vets, when they're sending a patient to us for surgery, if they tell the owner, yes, we've got deep pain sensation, when it's in fact actually just a reflex withdrawal, the prognosis gets much, much worse in that situation, and the owners may not want to have made that trip all the way down here from wherever to do surgery, or and go through the expense of travel and that sort of thing if the prognosis is poor. Now, myelomalacia is a really devastating syndrome. What happens is that you get impact to the spinal cord here, and then you get progressive dissolution or softening of the spinal cord going in both directions. And it's because of really, really severe compressive injury to the spinal cord. And it sets off a cascade where the spinal cord actually starts dissolving away. And it happens very, very rarely. I've only seen probably 2 or 3 cases in my whole career. But when it does happen, it's a very, very serious and grave prognosis. And so what we see is expanding neurolocalization. So whereas before we used to have a solitary lesion in the spinal cord, now we're losing anal tone, or the front limbs are flaccid when they used to be normal, that sort of thing. So we're looking for flaccid paralysis of the abdominal muscles, the pelvic limb, tail, anus, and bladder. You have lack of deep pain sensation. So myelomalacia cannot occur if you have deep pain sensation intact. So this is a catastrophic end-stage damage to the spinal cord. As it moves cranially, you can have respiratory paralysis, and these guys are excruciatingly painful. And it often occurs within 1 to 3 days of the start of clinical signs. So when we grade intervertebral disc disease, it's important to have a consistent grading scale so that we all know what we're talking about and we can all communicate. Grade 1 lesions are just painful, but they have no neurologic deficits at all. Grade 2 have some wobbliness or ataxia with no weakness. Grade 3 has weakness, but they still have some motor function intact. Grade 4 is paralysis, and then grade 5 is that loss of deep pain sensation. All right, so grade 1 is just painful, grade 2 is ataxia or wobbliness, grade 3 is weakness, grade 4 is paralysis, and grade 5 is loss of deep pain sensation. So when do we decide to go to surgery? There are a couple of different factors that we consider. Number 1 is the severity of clinical signs. If I have a dog that comes in and it's just a little bit ataxic in the back legs, or it just has some spinal pain and it started this morning or yesterday, I'm more likely to treat that dog conservatively, whereas if it's an excruciating pain and it's been going on for a month, that's one that I'm going to be more enthusiastic about going straight to surgery. Duration of clinical signs. So if I have a dog that's ataxic And it just, again, it started this morning. I'm less likely to go straight to surgery than if a dog has been ataxic for the last month, and it's a dog whose function requires that it has normal use of its back legs. Are they deteriorating, static, or improving? So I'm much happier to treat a dog conservatively if the clinical signs are improving or if they're static than if they're deteriorating. If I have a patient that comes in this morning and it was walking yesterday and it's not walking this morning, that's one that I'm going to rush to surgery compared to one that's been basically static for the last 3 weeks. And if they have neurodeficits, early surgery results in a more rapid improvement and more complete recovery than dogs that do not have neurologic deficit or that do not have early surgery. So if we find a dog that has neurologic deficits, we take it to surgery, it's going to recover more completely and more quickly than if we don't take it to surgery. All right, so what are signs that would suggest to us that we definitely need to go to surgery? Any dog that's paralyzed or has really significant weakness in the back legs. Any dog that has deteriorating neurologic deficits. So if you have a dog that started off walking yesterday and now it's paralyzed. A dog that's been painful for an extended period of time. And then, of course, those dogs that have lost deep pain sensation. Okay. One thing that's really interesting and important is that dogs that have a cervical disc rupture, so here we've got a nice big calcified disc that's ruptured onto the spinal cord. I don't think I've ever seen a dog lose deep pain sensation. So delaying surgery in a dog that has a cervical disc rupture is less of an issue than a dog that has a thoracolumbar disc rupture. So if I have a dog that comes in just painful on a Sunday afternoon, for a cervical disc, I'm less likely to take that dog to surgery than if it presents with a thoracolumbar disc. As far as imaging is concerned, we have a couple of different things available. The one that we use most frequently is a CT myelogram. What we do with a CT myelogram is that we do our normal CAT scan, so we're doing our slices through the spinal cord, and often we'll see a little area of calcification, but I almost always do a myelogram as well, because that myelogram is going to show us exactly where the compression of the spinal cord is. And so I have had cases that have had a calcified disc up here, have had a calcified disc sitting up here, and then when we do a myelogram, we find out that the actual compressive lesion is down here. Okay, so I'm generally not happy doing surgery just on a CT scan, even if I see a calcified disc. And I know a lot of people are happy to do that, but I've been surprised a couple of times when we actually do that myelogram to find out that it's a different disc altogether. MRI is really great, and if I had an MRI scanner, it would be great to use it, particularly in confusing cases. I do find that MRI tends to overinterpret the degree of compression a little bit, and so if I had an MRI in-house, I would still probably do a CT myelogram in the majority of cases, and then just do the MRI in cases where either the CT scan is not very helpful or that I don't get the results that I'm expecting based on neurological examination. So when you compare a CT scanner with an MRI, there are a few differences that you have to consider. The first is speed. A CT scan is going to be significantly faster than an MRI. And we can do a CT myelogram. So a CT myelogram we can do very frequently in about 10 to 15 minutes, and we can scan the entire spinal cord in that period of time, whereas an MRI, depending on the size of the magnet that you have, that procedure could take 45 minutes to a couple of hours. And so certainly speed is an advantage with CT scan, unless you've got like a 3 Tesla MRI, which is a very, very big human unit where the time becomes less of an issue. CT is going to be a lot faster. Generally, availability of CT is better than it is for MRI in our market. There are other markets, particularly in the US, where every referral hospital has an MRI. Unfortunately, in Melbourne, we don't have that availability. With MRI, there is a slight tendency, with MRI, there's a slight tendency to over-interpret, so it's going to show compression that may not be clinically relevant. big benefit of MRI is that there's no need for a myelogram, and it's safer, and you can also assess the condition of the spinal cord. Is there a lot of inflammation within the spinal cord that you're not going to be able to see on a CT scan? In most places that I've been and places that I'm aware of, it is uncommon to do an MRI as a primary diagnostic test. Usually people do conventional CT myelography and then do an MRI for the unusual cases. That also can depend on whether it's daytime or nighttime. Most of these seem to come in at night or on the weekends, and where you might have limited availability of MRI staff. And so on the nights and weekends, you might do CT myelography, whereas if they occur during the day on a Monday to Friday, they might be more likely to do MRI. So what are the objectives of surgery? What we're trying to do with surgery, the main thing we're trying to do is decompress the spinal cord. That's the number one objective. And we also are going to try to prevent recurrence at the same site by using fenestration. And I go back and forth on fenestration, and I was trained not to fenestrate discs when I did my residency because there was relatively little evidence to support the idea that fenestration reduced the recurrence of disc disease. But since then, there have been a few studies that have suggested that fenestration of the actual site that you're operating on is going to prevent a recurrent disc at that same site. And then the other really important thing is we have to be careful in there, and we have to prevent or avoid doing any damage to the spinal cord, more damage than what we expected. And we always tell clients that there's a 2% chance that we're going to permanently paralyze the dog with surgery. The fact is that that number should be quite a bit lower from actual iatrogenic or surgical trauma. I've had maybe one case that I paralyzed with surgery. Not maybe, I definitely had one case that I paralyzed with surgery in the last probably 20 years that I've operated on. The other thing to remember is that these are on a continuum of clinical signs, which means that if a dog was normal yesterday, paralyzed this morning, we take it to surgery, there's still inflammation going on in the spinal cord that may progress and deteriorate further despite the fact that we're decompressing it. So we can't take the blame for all of the deterioration with surgery, but certainly if you have a dog that comes in with deep pain sensation and maybe with a bit of motor function, and then with surgery it loses deep pain sensation and motor function and never walks again, that's probably one that we did, that we damaged during the surgery itself. And I had one, unfortunately, that happened to me about 4 or 5 months ago. I was drilling with the burr, and the burr grabbed onto the side of the bone and jumped in and hit the spinal cord. And I was absolutely gutted and devastated. And I can say that I have not had that happen to me in a thoracolumbar disc rupture ever before or since. So when we're doing our surgery, what we're doing is we're taking a high-speed drill, and we're going to go in and make a window in the vertebral canal. And that window has to be big enough to remove all of the disc material. Generally, we can use the CT scan or the CT myelogram to tell us how much disc we can expect to find. So if the spinal cord is sitting here and you see a lesion that looks like that on the myelogram, we can expect that we're going to get about that much disc material out. And so, if you have a very small disc rupture on the CT myelogram, you might be able to limit the extent of your laminectomy to something a little bit smaller, like that. So that's the benefit of using CT myelography or MRI over conventional myelography when determining how much or how large a window we're going to have to make in our spinal canal. So, and then the next thing that we're doing is a fenestration. So we're coming in. So if this is the spinal cord up here, and the laminectomy that we've done is from here down to about here. So all that bone is gone generally, and then we can come in with a burr or with a blade and make a window in the annulus fibrosus, and we're going to scoop out all that residual disc material to prevent it from rupturing dorsally onto the spinal cord. And that has been shown to significantly reduce the incidence of recurrent disc ruptures in dogs. So with surgery, if you have deep pain sensation intact, we get about a 95% success rate. And I would even say that it's probably closer to 98%. If they have deep pain intact and we get into surgery quickly, 98% of those dogs are going to walk again. And and in dachshunds, even with dogs that lose deep pain sensation, still about 75% of dogs are going to regain function. May not be completely normal. They may be ataxic, may have some issues with bowel and bladder control, but they are going to be functional pets in a lot of cases. So, progression following surgery. If we go into surgery and they have deep pain present before we started surgery and after we finish surgery, then most dogs are going to be regaining motor function within a week. Most dogs are walking within a week, and almost all dogs are walking within a month. And we used to actually have a guarantee at our practice that if they weren't walking within a month, they got their money back. But some people thought that it was kind of gimmicky, but in the whole time that we had that for about 2 years, we never had to pay out because every single one of the dogs that we operated on that had deep pain sensation was walking within a month. Recurrence, you have two different categories of recurrence. We have early recurrence and late recurrence. And early recurrence is probably, in most cases, more disc material coming out at the same site. That's in contrast to late recurrence, which is usually disc rupture at other sites. And what we think is that early recurrence probably results from failure to remove all the disc material from the spinal canal, and also, I'll put a note here, failure to fenestrate. And again, there have been a couple of studies in the last 5 or so years that showed that fenestration is going to reduce the incidence of local recurrence at that same site. Sometimes, if you're not confident with the amount of disc material that you've removed, you'll go back and do a CT scan after surgery, again, to make sure that you've gotten everything out. Generally, I'm pretty comfortable that I can access the whole spinal canal with my surgeries, and so I'm less likely to do a postoperative CT scan unless I'm concerned. Sometimes less experienced surgeons are going to go and do a CT scan afterward just to make sure until they get the confidence that they're able to access the entire spinal canal. So the risk of recurrence overall is about 10%, and that is highest in dachshunds. So that 10% that I'm quoting is actually dachshunds. If I have other breeds of dogs, I'm less concerned about it. If we see other calcified discs at the time of the initial surgery on the CT scan, that's going to predict a higher rate of recurrence. And interestingly, recurrent disc ruptures carry no worse a prognosis than the first-time ruptures. So just because they rupture another disc 6 months down the road or 2 years down the road, the prognosis is poor for your wallet or your bank account, but it's no worse for the dog as long as deep pain sensation is intact. So in summary, intervertebral disc displacement occurs frequently in dachshunds, with about 25% of patients developing disc disease. And remember that of those dogs, probably about 20% of those dogs that rupture discs are going to die of their disc ruptures. Okay, so we need to be aware of this. That comes out to about 5% overall of dachshunds are going to die of disc disease. And so by recognizing these clinical signs early, being aware of them, recognizing early, getting treatment early, and getting into surgery and decompressing them early is going to significantly improve our prognosis. In patients with paralysis, deteriorating clinical signs or loss of deep pain, surgery significantly is going to improve our prognosis. And there's a saying, when all you have is a hammer, everything looks like a nail. Just because you might not have all the tools available in your practice doesn't mean that another practice somewhere else might not have those tools, or might have those tools and may be able to better treat those patients. And so if you don't have surgery in your practice, they probably ought to be referred for evaluation by a specialist, because early intervention and treatment on these guys is going to make a big difference in prognosis. If you are either in practice and you're a veterinarian, or you're a pet owner and you have a dog that's predisposed to getting disc disease, this book is available on Kindle, and it is excellent when it comes to reviewing all the issues related to disc disease. So it's by James Fingeroth and Bill Thomas, Intervertebral Disc Disease in Dogs and Cats, available on Kindle. I bought it when I was preparing this lecture for the first time, and I have to say that I learned an awful lot. They do a very, very complete review of the literature and really explain things in a very, very clear fashion with respect to disc disease. Just showing off a little bit, this is our CT suite in our practice. We've had this for about 4 or 5 months. It was a brand new 16-slice CT scanner, and what that means that is every time the gantry rotates, we take 16 slices through the patient, and this rotates 2 to 3 times per second, which means that we're getting 32 to 48 slices per second. And so that's very, very fast. And this is not even the fastest CT scanner out there. They make a human machine, which is 324 slice with 2 to 3 slices per second, meaning, or 2 to 3 rotations per second, which means they can get up to 1,000 slices per second. And that's why they can do cardiac angiography and stuff, and they can scan the entire heart in a single rotation of the gantry. Very, very amazing, impressive technology. This is one of our surgery suites, so all decked out and nice and big and clean. And this is the first surgery that I did in our new hospital, and very proud to say my son was scrubbed in with me. He is a second-year medical student. That's Alex. My oldest son, Nick, is a fourth-year medical student, and he comes in and scrubs with me as well. And so anyway, that is all I have to say. That's the end of my presentation. So we'll fade back over to me if you'd like. So just push PIP and then click on me. So there I am. So I hope you enjoyed this presentation. I do have a lot of other lecture material available that I'm going to put out as time permits. We had a little bit slower day in surgery today, so that allowed me the time to present this. If you have presentations that you're interested in that you'd like us to talk about, I know James is going to do one on reconstructive surgery in March. We have all kinds of lectures on other types of cancers, abdominal exploratories, tumors, fractures, cruciate disease, all kinds of stuff. And so if you're interested, we would be very, very happy to hear from you, and we'll try to put on whatever we can. I will fade out on the video in just a couple of minutes or a couple of seconds, and then we'll stop the live stream, but I will man the broadcasting of the questions for about 5 minutes afterwards. So if you have any questions, don't hesitate to put those questions through. Anyway, thank you very much, and I hope to see you again soon.